Hello everyone, welcome back to the Whipple series. In today's video, we will demonstrate the Pancreatico-Jejunostomy, that is PJ, Duct-to-mucosa with modified Blumgart technique, that is with the help of horizontal U-stitch through the pancreas. Please read the detailed disclaimer in description of this video, and these videos are meant for education and information purpose only. So let's meet the Whipple of the Whipple operation, Sir Alan Oldfather Whipple. And in addition to the Whipple surgery, there are many contributions to the surgical field like Whipple's triad, and his legacy continues to inspire generation of surgeons worldwide. So the patient in which we will demonstrate the pancreaticojejunostomy in this video, she was a 49-year-old female with no known comorbidity. She presented to us with surgical obstructive jaundice and the cause was periampullary tumor. So these are the sagittal and coronal images of the CT scan of the same patient. Here you can see that there is an enhancing mass in the periampullary area as highlighted in this yellow circle, and there is a dilatation of CBD, IHBRD is dilated, and MPD is also dilated in the lowermost right hand corner panel. So this is the close-up view of the same sagittal image, and here this dilatation of the CBD, the anatomy of the portal veil, the enhancing periampullary mass is very well delineated. The viewers, the students can pause the video and understand this configuration better. So in this snapshot, here the dilatation of the CBD, the MPD is very well delineated. The enhancing mass at the periampullary is also seen. So viewers, you understand that the system is dilated up to the point of obstruction where is tumor. So the MPD and the CBD is dilated, and up coming to a point there is an abrupt duct narrowing. That is the case of the tumor. So what I want to tell you is that when you are analyzing these images, you trace the dilated structure, be it CBD or MPD, and where it is coming to the end or there is an abrupt narrowing, that is the place there is obstruction and there will be tumor. And these are the axial images. Here also we have discussed in this pen case also that the MPD, if it is visible up to the body or tail, that means we are dealing with the dilated MPD, and in this case the diameter of the MPD was around 4 to 5 mm, and it is better seen in these close-up images. So on CT scan, there is a presence of homogeneously enhancing mass of size 17 into 20 mm in the periampullary region with intraluminal extension in D2 segment, causing dilatation of PD measuring up to 5 mm, and CBD is also dilated measuring up to 11 mm with upstream IHBRD. The upper GI endoscopy confirmed the CT scan findings suggestive of infiltrated ulcerated ampulla, and biopsy was taken, which was suggestive of grade 1 neuroendocrine tumor with Ki67 index of less than 3%, which was positive for the synaptophysin. So now we are dealing with the NET grade 1 in the ampullary region. In this patient, we did Whipple, and in this particular video, we will showcase the pancreaticojejunostomy in this lady. So friends, as a prequel, all of you can watch our series or a video on the pancreaticojejunostomy so that you have a gradual and better build-up of the knowledge, and you will understand the basic difference in the PG and PJ, which we have discussed in quite a lengthy detail in this video. In a 22-year-old lady with SPEN, head of pancreas with undilated system, and the CBD was of around 2 to 3 mm. And in addition to this PG video, we have already uploaded around 5 videos in the Whipple series, and you can watch all these videos on our app or on our YouTube channel. So from the basic to the advanced, we are gradually progressing. And for exclusive access to the premium high quality content, you can download our app or join the premium or elite membership on our YouTube channel. The link for everything is given in the description of this video. So friends, when we talk about the PJ, pancreaticojejunostomy or pancreaticogastroscopy, so what is the rationale, how to choose one over the another? Many things were discussed in the PG video, pancreaticogastroscopy video, and there will be some overlap with the content. The incidence of post-operative pancreatic fistula, it is around 5 to 30% after PD. So, I mean, beside the morbidity, it also contributes to the mortality and longer hospital stay. If you're dealing with the HPV surgery, then we all of us know that if the patient develops a POPF, the course become prolonged, the hospital stay become prolonged, and the complications are high, and that is also cause of sepsis, higher bills, and even the bleed is also one of the late sequel of the POPF. So initially, it was proposed or hypothesized that the pancreaticogastroscopy (PG), the pancreatic enzymes are secreted the acidic environment of the stomach, and that they will not be activated because for activation they need a while. So there will be less chance of the POPF, but the literature has not, shown any. Has not supported this fact, and the leak rate after PG and PJ is equivalent. I'll share some of the good article related to the PJ, about which the viewers and students can read. As we talk about this modified Blumgart technique, so here is the legend, Sir Dr. Leslie H. Blumgart, and he recently left for the Hemley Adobe on 27 September 2022. And the HPV surgery can be divided into two halves, that one will be before Sir Blumgart and one after him, because his life's work took field from performing surgical resection and reconstruction with frequent complication, massive blood loss and high mortality, to a far safer and more effective era in the HPV surgery. And I hope all of you know that he started his career as a dental surgeon, and later on he did his work and degree in the HPV field. The pancreatico-enteric anastomosis, the sequel of POPF, the sequel of which is POPF, it has intrigued surgeons, motivating them to search for a more reliable technique to avoid this complication. And still, we have around 10 to 30% POPF rate, and still, I will say we have not reached or achieved the best or ideal technique of the pancreatico-enteric anastomosis. The paper which I have, the reference to which I have given here by Grobmeyer, in which Sir Blumgart is one of the co-author. So they said there are various methods of duct-to-mucosa anastomosis with or without invagination or seromuscular jejunal anastomosis. But the Blumgart anastomosis using transpancreatic U sutures has a favorable outcome in some trials. This is again a good paper or interesting paper, I will say, by Peng et al., in which they gave some kind of a novel technique of binding pancreaticojejunostomy and demonstrated zero POPF after 150 consecutive cases. But the issue with this technique of binding pancreaticojejunostomy shown by Peng et al., it has not been validated externally, and other institution or other surgeons has failed to show similar rates with such technique. Another interesting paper which viewers and students can go through is by Sir Arpun et al. From Hong Kong, and it is like external drainage of the pancreatic duct with a stent to reduce leakage rate of pancreaticojejunostomy after pancreaticojejunostomy. So what they did, they placed a stent in the MPD and externalized it through the draining limb, and they said it has minimum rate. So I personally have no experience, I have not seen this technique, but I feel it may be of some use in high risk cases, or like you're doing a trauma case where the duct is just 2 mm. So here you can place a stent and drain it externally to reduce the rate of POPF. So what are the characteristics of ideal PJ? So it should be applicable to all patients. It should be easy to teach, easy to replicate, and the association with the low rate of POPF. So, in this paper, they said, in which Sir Blumgart is also one of the co-author, that PJ described by one of the author, that is Leslie H. Blumgart, sir, meets the criteria of an ideal PJ. So, viewers, all of you can read this paper. That will add a more theoretical knowledge to the technique that we are going to discuss in this video. So, in this paper, the authors reported that a total 187 patients underwent pancreaticojejunostomy after pancreaticojejunostomy using the described technique. The overall mortality was 1.6%. The rate of clinically significant pancreatic anastomosis failure, that is the PUPF grade B or C, was only 6.9%, and there was no bleeding, reoperation, or mortality secondary to the pancreatic anastomotic failure. And so the noble pancreaticojejunostomy is applicable to all patients in whom the pancreatic duct can be identified and is associated with very low rates of significant postoperative morbidity and mortality. So friends, this is the paper you can read. So again, the idea here is that you should be able to identify the MPT or the pancreatic duct, then only you can do the duct-to-mucosa technique. The basic tenets of safe pancreaticojejunostomy will be: there should be careful handling of the pancreatic tissue, as in all the surgery. It should be tension-free adaptation. Both the jejunum and the pancreatic remnant should be good. Should have a good vascularity, good perfusion, and there should not be any distal obstruction to the draining limb. And if we follow these basic tenets of safe PJ, then any pancreatico-enteric anastomosis technique will have excellent outcome irrespective. So, the basic tenets of safe PJ are must to adopt. The option available to us are PJ dunking, PJ duct-to-mucosa, PG, which is easier to perform, less prone to ischemia. This paper I have discussed during the pancreaticogestostomy, that was a prospective randomized trial of PG versus PJ. And you can also go through this meta-analysis that has pooled all the data on the PG versus PJ. So the available evidence is that the POPF or the complication rate is similar in the PG oblique PJ, but there's a bit that the balance is tilting toward the PG, that it has a better overall outcome, but it has not reached the statistical significance, and the rate of post pancreatic hemorrhage is higher after the PG. So friends, the debate of PG oblique PJ we cannot settle in this video, but we follow is that if we have a favorable anatomy, the duct is dilated, and pancreas is good firm, then we follow the PJ, that is duct-to-mucosa modified Blumgart technique. If we are dealing with a soft pancreas, like in a case of SPAN or in case of trauma, then the undilated system, the watery pancreas, then our technique is PG. Rest you can choose as you grow and learn in your life. Now we will demonstrate the actual anastomotic technique in the part 2 of this video, in which we will do the duct-to-mucosa modified Blumgart pancreaticojejunostomy. First step will be to bring the jejunal limb to the right upper quadrant. There are two routes available. One can be through the ligament of Treats or through the mesocolon on the right side of the middle colic vein. And our preferred approach, and most of the time other surgeons also follow, is the jejunal limb is brought through the mesocolon on the right side of the middle colic vessel, because it has less chance of obstruction in case of local recurrence in the pancreatic bed. So now the pancreatic, this jejunal limb has been brought up through the right this mesocolon, and we have created an enterotomy in the jejunal limb. In this series, now we are left with the basically approach to the portal vein and the uncinate dissection and how to create the tunnel of love. So we will upload the remaining videos soon, as in when we get the opportunity to record a good quality video. And I hope you have already downloaded our app. If not, you can. The link for everything is given in the description, or you can join the premium or elite membership on our YouTube channel also to enjoy the premium and exclusive access to the SD content. So thank you very much, friends. I hope we were able to add some new insight to your knowledge, and I hope you have learned something new from this video. And do like the content, subscribe to our channel, hit the bell icon, and we wish you a happy learning. Stay tuned. Thank you very much. Happy learning.